to Vagina Talk. This is the podcast that's quite unique, in fact, where we try to uncover some of the very taboo topics surrounding the vagina. We also talk about wellness in general for women. The purpose of the podcast is really trying to open up lines of communication to really kind of break down all those crazy barriers that have been set all these years in regards to everything surrounding the vagina, what's between the legs. So what we thought we would do, something a little bit different and somewhat unique, is let's do a surgical series. You know, we're surgeons. That's what we do for a living. So let's talk about surgery. This is kind of the first episode of that series for us. So we're going to start with a topic called hysterectomy, something probably everybody knows something about, but we're going to delve into it a little bit deeper and kind of discuss, you know, what is a hysterectomy? Who should have one? What are the indications for it? Are there alternatives to hysterectomies? You know, does it change your life? What actions or reactions occur in the body from a hysterectomy? So I'm Dr. David Kimble, my lovely wife, Dr. Alexis May Kimble. And again, we thank you for joining us. It's just the two of us today, and have fun.
Let's start with the first question. What is a hysterectomy?
Well, if you take the technical definition of a hysterectomy, it is the removal of the uterus. Now, what's interesting is where's the derivation of hysterectomy? Like, let's say I need my gallbladder out. They call it cholecystectomy. Or let's say the appendix, appendectomy.
Or the prostate, prostatectomy.
Yeah, prostatectomy. Absolutely. So why is it called hysterectomy? Does anybody out there call in, let us know if you know why it's called hysterectomy? It actually comes back from way in the 18th century, back to Louis Mesmer. And they would actually take women and who they felt were hysterical and take their uterus out. And that was the derivation of the term hysterectomy. You're removing hysteria. Now, it kind of dumbfounds me that as a medical community, as a society in general, that we allow this term to persist. It's crazy. It should be 100% abolished from all textbooks. We should not teach this through the upcoming medical school class.
Because it certainly is not to remove hysteria, the indication for hysterectomy, at least in modern times.
It's insane. Right. It's crazy.
So really, the terminology should be
uterectomy.
Exactly. So the rest of this podcast, that's probably how we're going to refer to it.
Yes. Yeah. So how common is a uterectomy?
Well, what's commonly known as hysterectomy, but really is a uterectomy, is actually one of the most commonly performed procedures nationally for many indications. But it is it's almost, of the gynecological surgeries, oftentimes patients come in, you know, kind of rolling the word hysterectomy off their tongue, thinking that it's going to solve a lot of the problems they're presenting with.
Correct.
And a lot of the doctors they've seen prior to coming to us have often recommended a hysterectomy for various indications, some of which may or may not really solve the problem at hand.
Yeah, so if you think about it, traditionally, if you go back and look at the statistics of it, just in the US alone, the number one surgical procedure for OBGYN, or in general period, was considered a episiotomy, you know, a cut when you have a baby. Now that we've kind of had a societal push away from doing episiotomies, and maybe we can discuss it in a later podcast, but ultimately hysterectomy is performed over 600,000 times a year in the US. So that means 600,000 women every year get a hysterectomy. That's huge numbers.
It's a big number. Yeah. It's a pretty steady number throughout the years, unlike some of the other surgeries, which we've seen an incline, or like with episiotomies, we've seen a real decline, just it fell out of favor for many reasons. Okay, so let's talk a little bit about types of uterectomies. Let's talk about the types that are out there. Something we commonly hear is, I had a partial hysterectomy, or I had a total hysterectomy, or I had all different terminologies we hear from patients. We sort of just want to kind of debunk and clarify what exactly are the different types and routes that are possible with the uterectomy.
Yeah, so I think that was a great point that you made, just to kind of clear up some of the confusion around hysterectomy, uterectomy, is that when you say partial, it means just the uterus came out, cervix remains behind. When you say a total hysterectomy or uterectomy, that means the cervix and uterus came out. Has nothing to do with the fallopian tubes, nothing to do with the ovaries.
Right.
That's totally separate.
And that's the common misconception we hear, and a sort of disconnect when patients are trying to communicate to us. They're like, I had a partial hysterectomy, thinking that they have their tubes and ovaries, but their entire uterus has been removed, uterus and cervix,
Yeah.
which in fact does not translate to the same thing medically. That definition is very different. So,
yeah, I think one of the easy ways to kind of think about this, even as a patient, if you had your hysterectomy done as a vaginal procedure, you have a total. You can't have a
yes,
partial.
right,
There's
right,
there's no other option.
right,
It's a total.
right.
Now, if you had it done abdominally, or if you have it done more commonly now laparoscopically through small incisions or robotically, you can do either a partial or a total uterectomy.
Right, depending on the reason for your hysterectomy.
Yeah.
So let's go over different, so now that we've talked about the different areas that could be involved in a uterectomy, let's talk about the different routes that are possible.
Yeah, so I would say probably in today's world, the most common type of hysterectomy is laparoscopic.
True.
Kind of like how we do gallbladders and appendix, and even a lot of bowel surgery nowadays is done minimally invasively. The robotic technology first came into use and was approved in 2007 for gynecological purposes. And I think that's where myself and others were kind of early adopters in the robotic technology. And we tend to do a lot more that way than just basic laparoscopic in today's world.
Right. So laparoscopic,
Mhm.
robotic assisted laparoscopic uterectomies, abdominal, which you referenced, uterectomy, which essentially means big incision. It could be a transverse large incision, or it could be a vertical large incision. Traditionally, that's probably the most old-fashioned way to do it. And then you also referenced the vaginal hysterectomy, which is my favorite form of hysterectomy. But all of those are ways which we can access the space and get to the areas we need.
Yeah, absolutely.
Okay. Now, the route with which we decide how to approach it really depends on many different things, and that's really customized to the patient. What would you say about that?
Yeah, I think the worst thing that can happen is in a surgeon's armamentarium, they say, I only do open cases, or I can't do anything vaginally. I'm only going to do a laparoscopic. Because as you aptly say, there's many different reasons to do a hysterectomy. And that really kind of guides you in the appropriate route for a hysterectomy.
That's absolutely right.
Just like for you, we do laparoscopic hysterectomies, we do vaginal, we do robotic, but it really depends on the pathology and individualized, patient setting to make that determination.
Right. So it'll really depend on reason, the problem, the concerns, what we find on exam, what we find on our diagnostics, and the evaluation preoperatively for us to determine the most effective route.
Absolutely. Absolutely.
Okay, so we kind of segued into reasons or indications that someone might need a hysterectomy. What are some very common indications?
So probably the most common indication, heavy bleeding.
Absolutely. Yes, heavy bleeding. And secondarily to heavy bleeding, oftentimes it could be due to what's commonly known in layman's term as fibroids. That's very common.
And just think about it, just a little divergence here. A fibroid is overgrowth of the thick muscle of the uterus, and it tends to grow kind of like a ball of yarn in essence. So it's a bit encapsulated in itself, but fibroids can get huge. We've taken out fibroids that are literally like watermelon size. So, and fibroids aren't always benign.
Right.
Something we always have to keep in mind when we decide, should we have a hysterectomy for this? And what's the right route for that hysterectomy?
That's right. That's right. And the challenges of sort of a patient presenting for fibroids and, sort of surgical management of that is very variable from surgeon to surgeon. It could be a very challenging, complex procedure to remove them minimally invasively, especially laparoscopically or robotically assisted. And so that's really something important to consider. It's not uncommon that a patient will be counseled to have a very large open incision for fibroids. And that's something you just have to consider, especially in some of our young patients. So, the fact that the skills which are required to remove something that large should be something that should be considered by any patient considering why they're having hysterectomy and how they want it done in their healing process, because it could have long-term.
Totally.
Yeah.
It's your body, right? You have the right to make that decision.
Right.
You shouldn't say, oh no, I'm going to have some big scar down the middle of my belly because that's the only way this particular surgeon could approach this, or felt that they were most comfortable approaching it that way.
Right.
So I agree. In the world, you have to be your biggest advocate,
Right.
your health advocate.
Right.
Excellent point. Excellent.
But there is that option. So a lot of people don't realize that.
Mm-hmm.
Okay. What are some other indications, would you say?
Well, I would say probably the next most common indication is pelvic pain. And I think pelvic pain is derived from a multitude of different origins. From previous surgery, I have a lot of scar tissue. Endometriosis is an enormous cause of pelvic pain. Previous trauma can cause pelvic pain. Sometimes we really don't know what causes the pelvic pain, but we realize that there's a conglomeration of issues going on, and sometimes hysterectomy can help resolve that pelvic pain.
Right. So that would be another indication. And obviously, as urogynecologists, we often hear patients come in asking if they can have a hysterectomy to address prolapse. Or we are second or third opinion, and patients are requesting hysterectomy because that's what's been recommended to them by their previous gynecologists or urologists to address their prolapse. So we're going to sort of weigh in from our standpoint and sort of let you know what we think.
Yeah. So let me ask you, do you think a hysterectomy corrects prolapse?
A hysterectomy.
Or uterectomy.
Yes,
forget
uterectomy. I was just had to pause
Shame
for a
on me.
minute. Yeah. So it's not. The uterus is actually a very innocent bystander. There we go. In the world of prolapse. So that is not the culprit or the cause of uterine descent or uterovaginal descent, and it will not correct the problem entirely. Now, oftentimes, uterectomy is considered part of the surgical plan, depending on various factors, but it is not the sole surgery to correct the problem.
Yeah, absolutely. And, unfortunately, we commonly see a lot of patients come into the office. Oh, honey, I had my uterus out 15 years ago because I had prolapse. And then, within a year or two, I started to feel things. And now it's just all on the outside. It's terrible. Right. Because they had a hysterectomy for prolapse and it didn't resolve it. It can't.
Right. That's not the correct surgery. Or, there have been patients who have had a hysterectomy and, a couple of weeks later, they said their prolapse returned. And now when they come see us, they're very upset because we have to discuss a second surgery. Or, it has to be managed by conservative measures, which they've tried. And that was a reason they chose to have surgery, and it hasn't corrected the problem. So very important to make that distinction on indications for hysterectomy and the surgical plan.
Okay. Absolutely right.
So best route of hysterectomy, what would you say? Just to kind of take home points for some of our listeners.
I'd say minimally invasive route is always in your best interest. Right, you're going to heal quicker, less risk with the surgery itself, less risk that you're ever going to develop a hernia from a big open incision. So I think ultimately taking the most minimally invasive route, whether it's a vaginal route, laparoscopic, or robotic assisted, perfectly fine. Open abdominal, I would say, really should be limited to cancers that need to have much more invasive staging process going on, really extraordinarily large uteri, like up to the belly button and beyond, that you just can't remove safely as a laparoscopic approach.
Right. I would have to agree. Okay. And the other part is, what do we do with the cervix? So let's just go back a little bit with a very brief anatomy lesson. The uterus is one component, and part of the uterus is actually the cervix. We often refer to that as completely different organ, but really those two are one entity.
Correct.
So in deciding on how we approach a uterectomy, right, in our surgical approach, one of the questions we have to answer is, should we preserve the cervical portion of the entire organ?
It's an extraordinarily important point and really applies towards laparoscopic, robotic, or abdominal procedure. Like we mentioned before, when you do a vaginal hysterectomy, by default, you have to take the cervix out. There's no
Right.
technique of leaving that cervix behind and sneaking around it to try to get the uterus out. Can't happen.
Right.
So yes, I think we broach that question with our patients all the time. And a lot of that is patient dependent. If you've had a history of abnormal pap smears, you've had any like laser or treatment to the cervix, take it out. Well, why take the chance on leaving it there? But if it's not diseased, that's where the question comes into play. Should you take it out?
Right. So that's something we often make in collaboration with our patients after a lot of counseling. There's certainly pros and cons, risks and benefits to preservation of the cervix, as well as total removal.
Absolutely.
Okay. Would you say there are any added risks in performing a uterectomy where the cervix is also removed, what we would normally refer to as a total hysterectomy or total uterectomy?
Yeah, I would say from a surgical perspective, understanding the anatomy, that the bladders actually fuse to the upper cervix and lower uterus, there's a bit more dissection of the bladder to kind of
Absolutely.
find that appropriate surgical plane to remove the cervix.
Right.
The tubes that go from the kidney down into the bladder course very, very close to where that cervical area is. So there's a little slightly higher risk that you can have an injury to that tube called the ureter going from the kidney to the bladder.
That's
So
absolutely right.
I agree. I think there's a little bit of heightened risk with removal of the cervix itself. But I want to set the stage straight. This is not like skyrocketed high risk type issues
Right.
that can be overcome. We do it often.
Right.
So don't feel like, oh my gosh, I have to leave the cervix in because it's too dangerous to remove it. Not at all.
Right. And also, just kind of going back, the different routes of hysterectomies are associated with different levels of risk related to injuries of neighboring organs and viscera. So something we consider, we don't always necessarily, overwhelm you with those sort of details. That's something we have to consider as surgeons, but those are important questions to consider in your consultation with your surgeon.
Absolutely.
Okay.
So do you think leaving the cervix in helps out sexually? Do you think women who have a cervix there have better like orgasms, excitement? Is their sexual pleasure better?
I think that is a really important question that's been debated back and forth in our field, whether
For decades.
Yes. And when we look very, very purely at the data in the studies that have been formed in large patient populations, we've seen that removing the cervix does not affect sexual function. Having said that, we also know theoretically that the vagina is a place that harbors a lot of areas where there's a heightened female sexual response, not just theoretically the clitoral response, the G spot or the G zone or the clitoral uteral vaginal zone, but there's also what we call like the A spot that really borders that area where the cervix harbor, kind of sits and lives. And no one's really defined that very well. But I think when we talk about anecdotally, does it affect it? That's a big question mark. We don't really know. So I think that's something that we always have to kind of consider and discuss in our consultations.
Agreed, wholeheartedly. I think the reverse is also true. If you look at women who have left the cervix behind, do they complain of less sexual sensations? And the answer typically is no, they don't. So leaving the cervix behind really kind of allows you to preserve whatever sexual function you had before. You're going to have the same sexual function. Removing the uterus doesn't change anything at all. Doesn't alter your hormone levels, doesn't change the position of other organs in your body. Your body really does not recognize the loss of the uterus. And typically, unless it's a big fibroid uterus, it's about this big. So it's a very small organ that's being removed. So ultimately, I agree with you. I think, it's a personal decision. Do you want to leave the cervix or not? And that's that's a really important topic to discuss with your surgeon.
Absolutely, totally. And I think you brought up a really nice topic there, whether, having a uterectomy affects or puts a female in menopause. We get that often, like, oh, am I going to be in menopause because I had my uterus removed? I'm having a hysterectomy or uterectomy. What would you say about that?
Well,
you touched on it, so I just wanted some clarification.
Just really quickly.
Yes.
But ultimately, the hormone producing factor in the female body is the ovaries. That's where you get your hormones from, not the uterus, not the fallopian tubes. Now, do they respond to the hormones? Absolutely, but they don't produce them. So taking the uterus out alone does not at all alter your hormone milieu. You're the same. You're the same today as you were yesterday, pre-hysterectomy or uterectomy.
That's great. I agree with that. So, okay, well, we hope we answered a lot of some of the misconceptions and some of the things that you might want to consider surrounding the decision of undergoing a uterectomy.
Absolutely. And remember, when your surgeon says, oh, I think you need a hysterectomy, you should say, do you mean a uterectomy?
That's right. Have them visit Vagina Talk by Dr. Kimble. All right.
Hey, thank you, everybody, for joining us. It's always a true delight, and we hope it's been educational, informative, but most fun.
Great. If you have questions or topics you would like us to consider, such as this, which we receive from a lot of our audience, please feel free to visit our website, www.kimblecenterforpelvicwellness.com. Visit our podcast and submit your questions.
Yeah, awesome.
All right.
All right, everybody. Have a wonderful day.
Bye. Thank you so much for listening to Vagina Talk podcast. If you want to learn more, you can find us on our web, www.kimblecenterforpelvicwellness.com. See you next time.
Bye.